Good afternoon, everybody. Thank you very much for joining us today as Healthmonix and our partners at MDPortals are going to present Understanding HCC Scoring and Why It Matters. Today, we are joined by Jeff Larich. He will be our presenter moving forward through this presentation as I, Michael Lewis, will be hopping in intermittently to offer up a number of polls that we have, as well as interjecting some information about MIPS. Once again, my name is Michael Lewis with Healthmonix. We are MIPS registry, as well as we have other products in the value-based model. And for more information, you'll have our contact information at the end of this presentation. So without further ado, I am going to have Jeff get started and then introducing you to MDPortals and himself. So Jeff, take it away.
Thank you, Michael, and welcome everybody. So I'm Jeff Larich. I'm basically a senior advisor for MDPortals. I've been in the healthcare space for about 40 years, including significant amounts of time with large health plans like Kaiser and a lot of ACOs in my background, as well as large medical groups like Cleveland Clinic and Ochsner medical institutions in my past. MDPortals is really sort of a surprising solution to the interoperability. I started working with the founder last year and getting the product ready for market. We basically ingest and pull in all the data from not only resident EHRs, but also all the external EHRs, HIEs, and we also, the biggest chunk of it is out of faxes and labs and pharmaceutical data. And we combine it all into a searchable CCDA compendium, which we'll show you a little bit further here in the presentation. So basically, one of the things in my medical group experience that's been the bane of our existence is you have your patients, you have your information in your EMR, and then you're usually trying to go out and get the rest of the lab data, the data from the other referring doctors and hospitals and ambulatory surgery centers. And a lot of that stuff comes in basically unstructured fax data. And then you have to have someone try to come in and synthesize it and put it into a one composite longitudinal health record. Our system does that in almost real-time basis.
So real quick, I'm going to hop right back in. If you want to click forward to Jeff, there are a number of handouts that you'll be able to see on the bottom, as well as questions. Please ask your questions now or during the presentation, and hopefully if there's time to end, we will be able to answer them. If not, we will get back to you in a short time via email with your questions. As well as you can see, the handouts for this presentation are there. I will, at the end of this broadcast, be emailing everybody in attendance a copy of the handouts as well as the webinar recording for your viewing pleasure in the future. So before we get started, I did want to ask one poll question and go from there. So basically, we would like to understand what your understanding of HCC scoring is. Give it a couple more seconds.
Okay.
All right. So I'm going to share this real quick with everybody. It looks like most people are in the first three categories, except for it looks like we have an expert on the phone. I can't wait to talk to them. So thank you for joining us for this presentation, but this really helps us in how we move forward with the presentation on HCC scoring. So back to you, Jeff.
Okay, thanks, Mike. So our agenda for today is we're going to define HCC risk scoring, the mechanics and linkage to revenue cycle management, scheduling, contracting, EHRs, explain the relationship between physician documentation, coding and risk scoring reimbursement, and identify how that documentation affects RAF scores. We're also going to recognize how the coding affects the reimbursement and risk adjusted plans, which is primarily your ACOs and your Medicare Advantage plans, but it also will be starting to feed into the cost component of the MIPS scoring, which we'll talk about later as well. It also is starting to be used more and more by payers to evaluate medical groups and systems in their contracting, rate negotiations, and incentives for their plans. So we saw from the survey that there's about a third of you that maybe heard of HCCs but are not sure what it is, and then there's, it goes from there. HCC methodology forecasts the cost of care for patients with chronic conditions. The HCC or hierarchical condition category are disease groups that are broadly organized into body systems, and the diagnoses within each disease group are clinically related in terms of cost to the Medicare program. The risk factor scoring is the methodology within this that uses to assess the health risk and acuity using a numerical relational scale. Each payer may develop a different methodology, and they do vary from some payers to others, but we will be focused on the Medicare HCC today. The risk adjustment factor is a summation final scoring calculation assigned to a patient to assess the risk, resulting in payment calculations to the plan. It includes the chronic disease coefficient, age and gender demographics, dual eligibility status, and community status. A simplified way of thinking about it is the inverted pyramid. There's around 18,000 diagnosis codes out there right now. 3,000 of them are assigned to the HCC methodology, and there's 87 HCCs. The HCC is used to assess the patient risk and acuity and ultimately the cost in these health plans. So they're perspective in nature. They look at all diagnostic sources and chronic disease and the disease interactions between the different diseases, because many people have more than one disease, and they look at your demographics, which is your age, your sex, your race, etc. Here's a little simple example of some of the mechanics of scoring. I've worked with a lot of primary care practices, and you'll see in a lot of the cases, even in the health plans, that the type 2 or type 1 diabetes is usually documented without complications, and it has a risk coefficient of 0.104. And if they use long-term insulin, it again has the same risk coefficient of 0.104. However, there's very few diabetics that don't have other complications, such as hyperglycemia or mild kidney complications as the disease progresses. And that takes you up both of those to a score of 0.318. The monetary value of that is very easily illustrated. For the first 3 examples, it would result in a risk-adjusted payment of $749 for the year. If the coding was done and the diagnosis and information is properly captured, it would increase the reimbursement on that patient to $2,292 for the year, assuming a cap amount of $600 a month in Medicare Advantage sponsored plan. This is another example here of actual cases from one of our clients that basically we call it Jane Doe, and she was diagnosed with type 2 diabetes mellitus with chronic kidney disease. And hold on a second. And she had a total score, RAF score, before using our system of 0.119. This was based on claims data. The client put in a MDPortals request, which basically gets turned around usually in 24 hours or less. And we basically come back with suggested ICD-10 codes generated from all the clinical data from the EHRs, faxes, lab results, and pharmaceutical data. The green codes are all new ICD-10 codes with the increased numbers that were recommended. And the yellow one was the one that was the previous diagnosis code that was on this patient. The color-coded green indicates all the new ICD-10 codes that can be used to submit with this patient. Now, generally what happens timing-wise is if you do this kind of analysis and you get it in by June, you theoretically will get the increased monthly PMPM payments in January or February, but it can take sometimes anywhere from 6 to 18 months for the plan to get the increased payments. When the data comes back from our compendium, you can select from a table of contents on the patient and drill into it with the original source data that's all searchable. And you can use hyperlinks to highlight medications or conditions like the hyperlipidemia, which is usually a common complication of people with diabetes as well as hypertension. Here's another example again, you're using the hyperlinks to drill down in on the patient so that the mid-level or practicing physician could verify and validate any of this information as they see fit. There's a second case we call Jane Doe, where the patient had a score of 1.3, which is sort of more or less around what a lot of these cases have. He had the non-Hodgkin lymphoma and type 2 diabetes. When they turned in their request for this patient, the RAF score went up from a 1.3 to a 4.24, which is rather extraordinary, but there was all kinds of other complications picked up from other clinical records and lab tests and pharmaceutical records that we're able to track and capture. And you can see here that the documents that were analyzed are listed in the bottom here. So risk factor scoring for smaller PCP practices, a lot of them will say, well, I'm not really, bothered with it, or I don't understand it, and why should I care? Well, the movement to value-based care is a combination of looking at quality and cost savings. And to properly document the cost savings, you need to have proper documentation in the charts for the proper reimbursement for Medicare versus being under reimbursed or even over reimbursed if you do it the other way. So we did a survey as well about the documenting and coding HCCs, because most payers, the big five at least, do, and they control payments. So we asked the 700 organizations if they're coding for HCCs. 28% said yes, 40% said no, and 32% were unsure. Some of the comments we got back were really interesting. One respondent said our practice is 70% value-based, so we basically live and die by the attribution and risk multiplier for all our member per month calculations and contracts. One respondent from a specialty practice expressed significant frustration, and they're documenting more than ever, but they're not really gaining ground. And another poll respondent said their organization does not code for risk adjustment, and said they were advised it was suited mainly for primary care practices only. So there's a lot of confusion and misinformation out there. Value-based payments have arrived, and I think with the advent of COVID-19 and some of the other things we're dealing with now, it's going to accelerate. Most payers have or will implement payments based on patient acuity. The contract fee schedules are starting to be correlated to the level of patient acuity. Many of the big insurance companies are offering shared savings or other incentive payments to reduce medical costs while improving quality. And of course, we got all the shared savings, ACOs, and MSSP plans out there, and that is growing at a significant rate. And finally, MACRA and MIPS may have the most to offer special billing practices, but the cost component is a growing component of that, and that'll be influenced by HCC and RAF scores as well. So we had other survey. Go on.
So Jeff, I was going to jump in and throw a survey question in here if you don't mind. And
Sure.
It's basically asking our listeners which statements are true. I had to break up B into 2 categories, but you'll see it in 1 second. Feel free to choose as many options as you would like. Since there's multiple parts, I'll give some people a little extra time on here. Answers are coming in.
Cool.
And another 10 seconds. If everybody can get their answers in, that'd be great. All right, thank you very much. I'll just share the results so everybody can see what everybody chose here. And then as Jeff gets back into it, you'll get your answers right away. All right, Jeff, go ahead.
Okay. So the first statement is HCCs are assigned acute episodes of care is false. They are only assigned to select chronic conditions. So our advice is to keep your EHR problem list up to date with chronic conditions that need to be documented annually, and make it easier for your physicians to find the pertinent conditions, assess the patient, and document their status. The physician claim data statement is not being used for HCC scoring is also false. Physician office claims are the primary source for the diagnosis codes. And a study by 3M estimated that 80% of patients encounters incur in physician offices, so the integrated systems need to work really closely through their associated physician practices to capture that data. The third statement, networks will use cost and risk data to include or exclude physicians from participation. And we're seeing, as many of you know, a lot more narrow networks that are excluding physicians who are not compliant with quality metrics or who have significantly higher costs. And the payers are using cohorts of similar populations for benchmarking now. And ACOs, and I'm familiar with several of them, have started to disinvite participants if individual practice is negatively impacting their incentive awards. And this is only going to accelerate. So the goal is basically lowering cost and improving quality. And if you're going to see much more of this being used as a benchmark going forward over the next couple of years. And how do payers measure the quality and cost? As we were discussing, they use CPT and diagnosis codes. They obtain lab results from the national labs. They calculate and are getting much more refined on admissions, readmissions, exams, and ratios and benchmarks. There is a surprising amount of variability on the benchmarks around different parts of the country that a lot of health science researchers are looking at. They're also starting to closely monitor refill rates for chronic meds. The cost of care, again, is medical calculations and using the acuity scores and the risk adjustment scores. They're using that to calculate and compare across providers the cost of care. Here's just a simple risk scoring example of a plan and what those look like. And this is from one of the big 5 insurance companies. And a lot of the ACOs and medical groups are starting to be evaluated just like this. Okay, Mike, you want to jump into this? Okay.
I'm going to jump in right here just to let everybody know this is a very good time for you to get your questions in. We've had a couple come in, but this is a very good time to get your questions in. Jeff is going through these slides, and we do not have, we will have plenty of time to answer some questions at the end. So the complex patient
You're
bonus.
telling me I talk too fast, huh?
You are talking too fast. Yes. So the complex patient bonus. So this is very important because, as most are aware, MIPS is becoming harder and harder every year, and we at Healthmonix get a lot of questions from our customers asking us, "What can I do to get bonus points? What can I do to get extra scoring?" So the HCC has an impact in multiple areas in MIPS, but the first one is on the complex patient bonus. So you can receive an up to 5 points on top of your MIPS score. You can see from the bottom of the screen here how MIPS is separated in 2020, and then the complex bonus score comes in at the end. Added to the MIPS final score at the end, sorry. So based on the overall medical complexity and social risks for patients treated by the clinician or the group. So it's two parts that fill in the complex patient bonus. The first is the overall medical complexity and social risk, and the other part is the proportion of dually eligible patients treated. So people that are both on Medicare and Medicaid fit into this complex patient bonus. You can move to the next screen.
Yep.
So also the HCC will impact your cost performance score. So the cost not only in 2020, as we know that it is a lower percentage and moving up, by the year 2022, the government mandates that the MIPS cost component will be 30% of your score. So it's becoming more and more important as time goes on. So every cost measure, and this year we have all of the not only your MSPB and your TPCC measures, but we also have all of the other measures, the episode measures that are in there as well, are risk adjusted and account of variation for inpatient complexity. So the risk adjustment is fully dependent upon the HCC scores, and even a small change like 0.1 in an HCC score can impact your calculated risk adjustment by up to $1,000.
Yeah.
And these adjustments can significantly increase your score. So if you're able to take a look here what those deciles are for the cost measures, you can see what the impact on your score could be just in these categories here.
And that's on the individual and physician groups. And then on a similar fashion, the HCC score also affects all the plans and ACOs and Medicare Advantage. And a 0.3 increase in a RAF score there can increase the annual compensation to the health plan by over $3,000 over the next 6 to 18 months as well.
You got it. Perfect. All yours.
Okie dokie. So one of the other things that is interesting as we've been studying this over the last 18 months, there's a list here for your review later of the 10 most underdocumented HCCs and the 10 most overdocumented. And some of these are pretty common in the primary care office. You got asthma and pulmonary disease, skin ulcers, which usually tied to diabetics, the congestive heart failures, and the obesity are significantly underdocumented, whereas some of the ones on the other side are pretty much overdocumented. So again, something to take in advisement. So how can your practice obtain, compute, or monitor their HCC RAF scores for their health plan? As you all know, the payers will provide data files, usually sort of post-lag, 30, 90 days, and in some cases longer than that. They will only contain descriptive terms and no scores, and they may not be clear what claims period is covered. That's sort of been bane of my existence for a while. The electronic medical records links an HCC to a diagnosis, but does not construct a score, and there's no data lag, and usually does not adequately describe all conditions if a patient utilizes multiple physicians, which with the Medicare population, that's very common. The analytics and data warehouse side of this, maybe they're usually built using payer or practice data or both, and they calculate scores and adjust costs, and their capacity is usually to perform historical and project financial calculations. The difference is MDPortals has this stuff on pretty much a real-time basis from all the outside data sources plus the internal one, that you can actually get a much better picture and improve your documentation and score and transfer that data into your EHRs to basically help your plans or your medical groups get the appropriate reimbursement from Medicare. There you go.
Sure. So feel free to ask any questions. You could send those questions to me, Mike Lewis, mlewis@healthmonix.com. We will be able to answer your HCC questions and utilize our partnership with Jeff to get your answers for you. So please reach out to me, and I am here to help you and here to get you where you need to go. As we know, HCC scoring has become very popular, and it is not an easy topic to understand, and that's why we are putting on these presentations. So we do have a number of questions that came in, and I'm going to run through them with Jeff. But give me 1 minute as I calculate some information here, and then I'll get started with the questions for Jeff. All right. So the first question comes from earlier in the presentation when you said boost the reimbursement. Do you mean the reimbursement from CMS to the Medicare Advantage plan to cover that patient costs?
Yes, it usually takes, depending on when they get the rest of the records in and update the HCC RAF score. If they get it done by June 1st, they can expect the increased PMPM adjustment hopefully in January or February, but it could take up to 12 to 18 months, but the Medicare Advantage plans do get that reimbursement.
All right, thank you, Jeff, appreciate that. The next question is, will I be able to get my HCC data through Healthmonix, or do I need to contact MDPortals themselves? I could take that one, Jeff. You can reach out to me.
Venture, so go ahead.
There you go. You can reach out to me, Mike Lewis. My information is still on the page right now. You could get information on HCC scoring and how we can help you with it directly from your partners here at Healthmonix. Most of you are very familiar with us already, so if you want to reach out to me, I am here to help you. Do you code the chronic conditions in every visit? Does the long-term drugs get a score?
Long-term drugs should be included in some of the scoring. There are certain categories where it is appropriate. You saw it in one of the samples I had up on the screen where we captured that. The coding for the HCCs is done on an annual basis. You get in and do it, and then you got to update it the following year again or revalidate it. Basically, and as patients age, their conditions get changed, so it's a good idea to do it. Just like the annual wellness visits and all that feeds into it on an annual basis too.
Great. All right, let's keep going here. Another question here is, we just recently received a large chart review from Medicare Advantage plan. Do you think it has something to do with HCC scoring and what's going on?
It possibly could. They're probably going to be looking for overcoding and undercoding, but since they're a Medicare Advantage plan, I think the main interest is going to be in getting the appropriate reimbursement for all the patients and the chronic conditions that they have. So I would suspect that it's going to be a mixed report, and you're probably going to get some pretty interesting documentation on that. I've been through 2 of those in my career, and they're interesting, and sometimes they can be quite helpful.
Terrific, terrific. So this next one's a little longer, but the questions come throughout. So I understand we should do this on all patients, but we are now just getting started with HCC coding. Should we start with Medicare patients first and then expand as time allows? We know we can't stop.
That's a reasonable approach to start with the Medicare patients and really learn, because those are the ones that it's going to have the most impact for you, both for the risk plans as well as even the Medicare fee for service with all the MIP scoring as well. So I would definitely start there and put together your operational and coding plans and processes, and then I would expand it down into the younger population. But your biggest pickup and improvements is going to be starting with the Medicare population for sure.
Terrific. They also have more comorbidities, so that will definitely have a larger impact there. How does
place to learn? It's a good
exactly.
It's like you say, it's a good sandbox.
All right. Couple more questions here. How does HCC impact the target price? Does the target price increase by a certain percentage with every HCC identified?
I'm going to have to look into that one and map it out. I don't have that information right in front of me.
Okay, no problem at all. All right, this one. Can you speak about RAF gap score? What is it?
Well, your risk adjustment factor is the different numbers within all the categories that comes up to your RAF score at the top. And if you have a gap in the score, that's the identified gap from the documentation and whatnot that was missing that we track in our system as we do the additional reporting.
Great. One other question we have here is you went over a case study that you were showing earlier and on Jane Doe, and there's a lot more detail I'm sure is involved in that. Is there anything that you can share with us on that detail? I know you may have some more slides you could bring up on that.
I have a web link that I can share later on that you can go in and click into the details on it that we could share.
All right, terrific. That'd be great. I think that would really help people in understanding HCC scoring moving forward.
Yeah, it's a very robust web link, and you can go into all the different data and drill down into it.
Great.
To the extent it's de-identified, but you'll be able to see a lot of data richness in it.
Okay, thank you.
Yep.
So an HCC, do you have access to lab data as well?
We have access to pretty much 95% of all the lab data in the country.
That's fantastic.
And the other thing too is for primary care especially, about 60% of the data that comes in is fax data that is basically unstructured. Some of our customers don't even look at their fax data anymore. They send it to us and we put it with the other data into the compendium so that it's already got the diagnosis codes and everything laid out per the sample that you saw in the presentation. Because there's a lot of data in there that most groups and plans have to dig through and try to figure out, what codes in that. And we cut out all that work, and it's almost real time.
All right. I'm coming down to the final question, so if anybody has anything to add, this would be the time to do it. Actually, I don't even know if you're going to have time because I know this topic is dear to your heart, Jeff, and what you're talking about, but are HCC methods going to change in future years? What does it look like in 2021 moving forward? I think you could probably spend the next 20 minutes talking about that.
Yeah, the HCC methodology is going through a conversion up through 2022 to much more of a claims-based and cost-based methodology. And most of my friends in the Medicare Advantage and health plan space are anticipating, all things being equal, that the health plans are going to experience about a 20% reduction in reimbursements from the new methodology as it's implemented, which again sort of behooves everyone that's going to have to play in the sandbox that they got to really improve on their HCC RAF scores now and get the coding and accuracy up to help offset the anticipated drop in reimbursements.
So this question, and this may need to be answered at a different time, but the AMA has said that in 2021 EMM codes, one is not to use a diagnosis of any disease that is not treated or addressed. How is this to affect HCC scoring?
I'd have to look into that and see.
Okay, terrific. Yeah, that is news to myself. So that would be a question that we could get to later.
Yeah, I'll get it to my medical director and have him look at that.
Do HCC codes have to be diagnosis from the physician, or can it be done by a nurse?
They have to, basically the documentation has to be there and basically approved by the physician. A lot of places use nurses to help get the stuff organized, but the physicians are actually supposed to review and oversee and validate the diagnosis codes and the medical information in the chart.
Great. Are HRA forms a must?
What are HRA forms?
That was a question. I don't know. I'm sorry. I thought it was something that was out there. So we'll take a look into that question as well for sure.
Yeah. Might
so if
be
there's
using different terminology than from our system in that, but it's probably a health risk adjustment form is what they're referring to.
There you go. That would be my guess. Yes. Yeah. Yes, that's what they're talking about. I got a response from them. So is a health risk adjusted form a must?
If you're updating your information to CMS, I'll double check with my system, but I believe that you probably need to put them in to get the proper documentation in the CMS.
Great. And we'll follow up with that question as well for you.
Yep.
But I like to normally keep this to about 40-45 minutes, give you guys 15 minutes back on your day. So really appreciate it. And once again, if you need to contact me, my information is right below. Michael Lewis, mlewis@healthmonix.com, and there's my phone number, and I could get you in touch with Jeff, and then we will be able to work on this moving forward. Everybody have a wonderful day, and please let me know if you have any questions. Look forward to talking to you soon. Thank you.
Thank you all for attending.